12 years ago, I stood in a hospital corridor, not as a physician, but as a son, watching a resuscitation team work on my mother. She was 72 years old. She was healthy by every conventional measure. Her annual blood work was normal. Her blood pressure was well controlled. She walked every morning without fail, had done so for 30 years. She was the kind of woman who never missed a checkup, never ignored a symptom, and never gave her family a reason to worry about her health. And she was my mother, which means that I, despite 19 years of practice as an interventional cardiologist and over 3,100 procedures, had never once sat across from her at the dinner table and had the conversation I had with hundreds of my patients every single week. I had never told her what was happening inside her cardiovascular system in the specific window between her alarm going off and the moment she collapsed on her kitchen floor. My name is Dr. Adam Smith. I have spent my career opening blocked arteries. I understand blood, vessels, and the mechanics of cardiac events as well as anyone in my field. And I am making this video because the question that the attending cardiologist asked me, quietly, carefully, in the hallway while my mother was being stabilized, was the question that changed everything I thought I knew about communicating cardiovascular risk. He said, "Walk me through her morning, from the alarm to the kitchen floor. Everything." I walked him through it, and as I described each step, the rushed getting up, the skipped water, the black coffee, the walk she went on before eating, the cold shower she took when she got back, I watched his expression change. Not with surprise, with recognition. What happened to my mother that morning was not random. It was not simply bad luck. It was a predictable and preventable convergence of 5 cardiovascular insults, each one stacking on the last, in the most hemodynamically vulnerable window of the entire day. She survived. She recovered fully. And the first thing I did when I returned to my practice was redesign the way I talked to my patients about mornings. And the second thing I did was call my mother and walk her through everything I should have told her years ago. Before I describe the 5 mistakes, tell me something. What is the first thing your hands do when your alarm goes off tomorrow morning? Not what you intend to do, what you actually do. Do you reach for your phone? Do you sit up immediately? Do you head straight to the kitchen? Leave it in the comments. No judgment. I want to understand where this community is starting from. And I want you to be honest with yourself, because that honesty is the starting point of every meaningful health change I have ever witnessed in a patient. My mother, when I asked her the same question after her recovery, said, "I get up. I make coffee. I go for my walk. Same as always. Same as always." That phrase, said with a kind of pride, is the phrase I have thought about every day since. Because same as always, in the context of a 72-year-old cardiovascular system navigating the morning hemodynamic storm, is not a reassurance. It is a risk profile. Here is the physiological reality that my mother's cardiology team explained to me in that hospital corridor, and that I have spent the past 12 years communicating to every patient I believe needs to hear it. Your cardiovascular system does not wake up gently. It activates in the 30 to 60 minutes before your alarm goes off, driven by your body's internal circadian clock. A cascade of physiological events begins preparing your body for the metabolic demands of waking. Cortisol rises sharply, peaking in the first 30 to 45 minutes after waking. This cortisol surge drives glucose into the bloodstream, raises blood pressure, and increases the contractility of the heart, all appropriate preparations for activity. Simultaneously, your platelet aggregability increases. The blood's tendency to clot rises during this pre-waking window, an evolutionary adaptation for potential injury, but a dangerous one for anyone with even subclinical coronary artery disease, in whom a hypercoagulable state in already narrowed vessels creates the conditions for thrombotic occlusion. And you are profoundly dehydrated. 6 to 8 hours without fluid intake, combined with overnight respiratory water loss, has reduced your circulating blood volume and increased blood viscosity to its daily maximum. The Journal of the American Medical Association published landmark research identifying the period from 6 a.m. to noon as the highest risk window for myocardial infarction, sudden cardiac death, and ischemic stroke in the general population, with the peak falling between 6 and 9 a.m. The researchers attributed this circadian risk concentration to the convergence of cortisol surge, platelet hyperaggregability, and elevated morning blood viscosity. Your mother, my mother, your parents, your neighbors, People all over the world wake up into this hemodynamic storm every morning, and then add 5 specific cardiovascular insults to it before they have finished their first hour of the day. Here are those 5 mistakes. Mistake number 1. Jumping out of bed immediately slash the hemodynamic reality. When you lie down, the hydrostatic pressure in your cardiovascular system is equalized across your body length. The moment you stand up, 300 to 500 milliliters of blood shifts gravitationally into your lower extremities within seconds. Your body compensates through the bear reflex. Pressure sensors in your carotid sinus and aortic arch detect the drop in central venous pressure and trigger immediate sympathetic responses. Heart rate increases, peripheral vessels constrict, and blood pressure is restored. In a young, well-hydrated, pharmacologically unaffected cardiovascular system, this compensation is rapid and seamless. But in a morning dehydrated, cortisol-surging, sympathetically activated older adult, particularly one on antihypertensive medication that blunts the bear reflex, this compensation is slower and less complete. The resulting orthostatic hypotension, systolic blood pressure drop of 20 millimeters of mercury or more upon standing, is not simply a lightheadedness issue. The reflex compensatory tachycardia it generates in an already coronary stress system is a genuine arrhythmic and ischemic risk. The blood pressure oscillation between the hypotensive trough and the subsequent overcompensatory hypertensive spike creates mechanical stress on arterial walls at their most vulnerable morning state. Research published in Hypertension, the American Heart Association's blood pressure journal, found that morning orthostatic hypotension in adults over 60 was independently associated with a 2.1-fold increase in cardiovascular event risk over a 7-year follow-up period, after adjustment for standing blood pressure, antihypertensive use, and baseline cardiovascular disease. The fix, step 1, the awakening minute. When your alarm sounds, do not move. Lie still for a full 60 seconds. Take slow, deliberate diaphragmatic breaths. Then roll to your side. Do not sit straight up. Pause on your side for 20 seconds. Then push yourself to a sitting position using your arms. Sit at the edge of the bed for a full 30 seconds before standing. This 2-minute transition converts what was a hemodynamic shock into a graduated physiological adaptation. My mother got out of bed the same way she had for 50 years, swinging her legs over and standing immediately. It was habitual. It was automatic. And it was one of 5 things that nearly took her from us. Mistake number 2, not drinking water / the hemodynamic reality. By morning, your hematocrit, the proportion of your blood volume occupied by red blood cells, has risen overnight as plasma water has been lost through respiration and insensible perspiration. This increase in cellular concentration produces a measurable increase in blood viscosity. Blood viscosity is not an abstract laboratory concept. It is a direct determinant of cardiovascular workload. The more viscous the blood, the greater the pressure required to move it through the vascular system, and the greater the tendency for it to form clots at sites of turbulent flow or endothelial disruption. In the coronary arteries of older adults, where atherosclerotic plaques create exactly the turbulent flow conditions that favor thrombosis, morning haemoconcentration is a direct contributor to the circadian peak of myocardial infarction risk. The clot that occludes a coronary artery during a heart attack does not typically form in a smooth, undamaged vessel. It forms at a site of plaque disruption, and the viscous, hypercoagulable morning blood creates the hemostatic environment in which that clot propagates from a small fissure into a complete occlusion. A study published in Thrombosis and Hemostasis found that plasma viscosity in the first hour after waking was significantly higher in adults who did not consume morning fluid compared to those who drank 500 milliliters of water immediately upon rising, and that this viscosity difference was measurable within 30 minutes of the hydration event. The researchers estimated that morning hydration reduces plasma viscosity to levels equivalent to a 2-hour improvement in hydration status. The fix, step 2, the hydration minute. 300 to 400 milliliters of room temperature water placed on your nightstand the night before, consumed within 5 minutes of waking. This is the single highest impact cardiovascular habit available in the morning routine. It costs nothing, takes 60 seconds, and begins reversing the hemostatic vulnerability of morning blood before any other demand is added to the system. My mother drank coffee first. She had done so since her 30s. By the time she walked out her front door each morning, she had consumed 2 cups of coffee and not a single glass of water. She was beginning every walk with honey-thick blood and a stimulant that was simultaneously elevating her heart rate and blood pressure. Mistake number 3. Coffee on an empty stomach. Before mistake 4, if you are finding this information genuinely important, please subscribe to this channel right now. The people who need this information most are not finding it because the algorithm has not been told this content matters. One subscription changes that. And the next 2 mistakes are the ones that most directly apply to the morning patterns I see most frequently in patients over 55. I want this to reach every son and daughter watching this who has never had this conversation with their parents. Your subscription makes that possible. The haemodynamic reality. Caffeine's cardiovascular effects are mediated primarily through adenosine receptor blockade and subsequent adrenaline release. In pharmacological terms, caffeine is a mild but consistent sympathomimetic. It mimics and amplifies the sympathetic nervous system's cardiovascular effects. The morning cardiovascular system is already in a state of elevated sympathetic tone. Cortisol is high. Adrenaline is already somewhat elevated. Heart rate and blood pressure are at their daily peaks. Adding caffeine to this system is not the same as adding caffeine to an afternoon system in a stable, fed, hydrated state. It is adding fuel to a fire that is already burning hot. The specific problem of coffee on an empty stomach is gastric absorption rate. Without food present to slow gastric emptying, caffeine is absorbed into the bloodstream with exceptional speed. Peak plasma caffeine concentration occurring within 15 to 30 minutes of consumption in a fasted state. This rapid peak produces a sharper, more pronounced sympathomimetic response than the same caffeine dose consumed with food, which produces a slower, more gradual absorption curve and a blunted cardiovascular peak effect. A study from the University of Barcelona published in the British Journal of Nutrition found that fasted morning caffeine consumption produced systolic blood pressure elevations averaging 8 millimeters of mercury higher than the same dose consumed with a mixed meal, with the effect most pronounced in habitual coffee drinkers over 55. The researchers concluded that the haemodynamic impact of morning coffee is significantly modified by food co-consumption, with fasted consumption representing a meaningful cardiovascular stressor in at-risk populations. Eat first. Even a few bites of food before your first coffee dramatically changes the absorption kinetics of caffeine. A banana, a handful of nuts, a piece of toast, anything that slows gastric emptying. Additionally, delay coffee until at least 60 to 90 minutes after waking, when the cortisol peak has begun to descend and the additive sympathomimetic burden of caffeine is reduced. Mistake number 4. Intense early morning exercise. Before the final mistake, please hit the like button if this video has given you information worth having. One tap prevents this from being buried, and I genuinely want this to reach the people for whom it matters most. And before we continue, everything I am sharing today is general cardiovascular health information based on published research. It is not personal medical advice. Your individual risk profile, medications, and health history must be discussed with your own physician. Please do not make significant changes to your exercise routine without consulting your doctor. The haemodynamic reality. Exercise is one of the most powerful cardiovascular protective behaviors available. I prescribe it to virtually every patient I see. The question is not whether to exercise. The question is what the physiology of your cardiovascular system looks like when you begin exercising, and whether the intensity of your morning exercise matches the state of the system it is being applied to. At the moment of peak morning cardiovascular stress, haemoconcentrated blood, elevated cortisol, elevated platelet aggregability, elevated sympathetic tone, adding vigorous exercise places a sudden, large oxygen demand on coronary arteries that are simultaneously carrying more viscous, clot-prone blood, operating under increased vasoconstrictive sympathetic tone that reduces their ability to dilate in response to increased demand and exposed to their highest daily level of circulating inflammatory cytokines from the overnight inflammatory fluctuation that is part of the circadian rhythm. This combination, high oxygen demand from exercise meeting reduced oxygen delivery capacity from vasoconstriction and impaired coronary reserve, defines exercise-induced myocardial ischemia. and in a population of adults with undiagnosed subclinical coronary disease, which is the majority of adults over 55, the disease being present but asymptomatic. It is a credible and consistent trigger for acute cardiac events. My mother's morning walk was not vigorous by most people's standards, but she was 72, dehydrated, caffeinated, and she went out the door within minutes of waking, before eating, before hydrating, directly into a haemodynamic system that was already under morning stress. The walk itself was not the problem. The walk in that specific physiological context was. A study published in Circulation found that the relative risk of acute myocardial infarction during vigorous exertion was 6.1 times higher in habitual non-exercisers and 2.4 times higher even in habitual regular exercisers, with the risk multiplicatively elevated when the exercise was performed during the early morning hours compared to later in the day. Walk in the morning. Stretch. Perform gentle yoga or mobility work. Save vigorous exercise for late morning or afternoon. If morning is your only window, a minimum 20-minute graduated warm-up at low intensity before any elevation and heart rate above 100 beats per minute is the non-negotiable cardiovascular safety requirement. Mistake number 5, extreme cold exposure. The hemodynamic reality. Cold exposure activates the diving reflex, a complex autonomic response evolved for breath-hold diving that produces immediate peripheral vasoconstriction and bradycardia when cold water contacts the face, and more generalized peripheral vasoconstriction when cold water contacts the body surface. The peripheral vasoconstriction of whole-body cold exposure is profound. The arterioles supplying skin, subcutaneous tissue, and peripheral musculature constrict rapidly and significantly, diverting blood toward the core and dramatically increasing peripheral vascular resistance. The hemodynamic consequence is an acute, significant elevation in blood pressure. The heart is now pumping against substantially increased resistance. In a healthy young cardiovascular system with compliant, elastic arterial walls, this pressure surge is accommodated and dissipated without incident. In an older adult with arterial stiffness, which is present in virtually all adults over 60 to varying degrees, with hypertensive vascular changes, with atherosclerotic burden that has reduced the compliance of major vessels, the pressure surge produced by a cold shower lands on a system with reduced capacity to absorb it. The coronary arteries, already in the vasoconstricted state of morning sympathetic activation, may vasospasm in response. The elevated pressure may disrupt vulnerable plaques at sites of atherosclerotic narrowing. My mother took a cold shower every morning of her adult life. She considered it invigorating. She considered it one of her healthy habits. I had never once, in 19 years as a cardiologist, told her what that cold shower was doing to her blood pressure in the context of her morning physiological state. A 2019 study in the Journal of Physiology found that head-out cold water immersion in adults over 60 produced acute systolic blood pressure elevations averaging 18 millimeters of mercury, with a subset of participants with established hypertension experiencing elevations exceeding 30 millimeters of mercury. The researchers identified morning cold exposure in older adults with cardiovascular risk factors as a practice warranting specific clinical caution. The fix, step 5, the transition minute. Begin every shower warm. Warm water promotes peripheral vasodilation, the opposite of the constriction we want to avoid. After your other morning protocol steps are complete, after you have hydrated, after your system is stabilized, if you choose to include any cool water element, do so gradually at the end of a warm shower, never as the opening experience of a dehydrated, cortisol-surging morning body. Here is the protocol that emerged from 12 years of reflection on what happened to my mother, and from the cardiovascular physiology that explains each of these 5 mistakes. Step 1. The awakening minute. Alarm goes off. Stay horizontal. 60 seconds of slow diaphragmatic breathing. In for 4, hold for 2, out for 6. This is your parasympathetic reset, the autonomic brake applied before the morning accelerator engages. Roll to your side. Push to sitting. Pause. Step 2. The hydration minute. Reach for the water you placed on your nightstand the night before. Room temperature. Drink 300 to 400 milliliters over 60 seconds. Before your phone. Before coffee. Before anything. You are thinning morning blood and restoring plasma volume before any cardiovascular demand is added to it. Step 3. The adjustment minute. Feet flat on the floor, perform 20 slow ankle circles each direction. These activate the calf venous pump, improving venous return from the lower extremities and preloading cardiac filling before you stand. Your baroreflex will now have a better filled system to work with when you make the postural transition. Step 4. The activation minute. Gentle shoulder rolls, neck rotations, seated trunk twists. You are warming connective tissue, incrementally raising heart rate, and activating peripheral circulation before any weight-bearing movement demands sudden cardiovascular adaptation. Step 5. The transition minute. Stand slowly. Pause standing for 20 seconds. Walk at a comfortable pace. Your cardiovascular system has now been given a 5-minute graduated runway into the demands of the day. Every step of this protocol is grounded in cardiovascular physiology. Every step directly counteracts one of the 5 morning mistakes. And the entire protocol costs 5 minutes. 5 minutes that could not matter more for a cardiovascular system navigating the most vulnerable window of its daily cycle. My mother is 84 years old now. She still walks every morning. But she walks after the awakening minute, after the hydration minute, after breakfast. She starts her shower warm. She takes her time getting out of bed. She drinks a full glass of water before her first cup of coffee, every single morning, without exception. She changed her routine because I finally told her what I should have told her years before. And she is here, sharp, active, stubborn in the best possible way, because that conversation happened in time. I am making this video so that you can have that conversation with the people you love before something forces it. 3 specific asks before you close this video. Subscribe and turn on notifications, because I post cardiovascular health content every week that is grounded in the same research basis as today's video, and this community grows 1 subscription at a time. Share this video with 3 specific people. Not a general share, 3 specific people whose morning routines you know. The parent who gets up the moment the alarm sounds and is immediately in the kitchen making coffee. The person who showers cold and considers it a health habit. The sibling who walks hard before eating or drinking anything. You have information they do not. Sharing it is not an inconvenience. It is the most direct act of care you can perform for their cardiovascular health today. And leave a comment telling me, specifically, which step of the 5-minute protocol you are implementing tomorrow morning. Step 1, Step 2, all 5, tell me. A public commitment is a commitment you are significantly more likely to keep. Prevention is the greatest act of love. I know what that phrase means in the fullest sense, because I stood in a hospital corridor watching people try to save my mother's life. And I know what it means on the other side of that, because she is still here, and she now knows everything I should have told her much sooner. You now know it too. Start tomorrow. 5 minutes. 1 step at a time.